Good morning, everyone. Welcome to Department of Medicine Grand Rounds, to everyone in the room, and also, of course, to everyone who's here online with us. For most everyone, I'm probably a new face, and I look forward to meeting many or all of you over the course of months and years. I'm the new Divisional Director for Physical Medicine and Rehab, and Narman, being away this week, asked me to step in and fill her big shoes. When she did, I kind of paused for a second, and I thought, no, her feet are way smaller than mine, so I can probably actually do that. So I have the pleasure of hosting Grand Rounds this morning. Before we begin, I'd like to respectfully acknowledge that we're located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, and Anishinaabe, Inuit, and many others whose histories, language, and cultures continue to enrich our vibrant community. And so that we don't take any time away from our esteemed speaker, I'll just take a minute to introduce him and then actually hand the mic over to you, Beto. Dr. Loyola-Sanchez completed his medical and specialty training in Mexico City and his research training at McMaster University, including both his MSc, his master's, and his PhD. And at the University of Calgary, did his postdoctoral studies as a Banting Scholar. Since then, he's been working on developing a program of mixed methods research to design, implement, and evaluate community-based rehab programs for people living with disabilities produced by chronic illnesses in outreach communities. This program focuses on implementing community-based participatory action research projects for underserved populations living with chronic complex musculoskeletal conditions, such as Indigenous rural communities in Mexico, as well as for people living with complex chronic neurological disabilities in Alberta. He's currently working in a spinal cord injury program at the Glenrose Hospital here in Edmonton and provides care to people with spinal cord injury in acute inpatient rehab as well as community settings. He leads several community-based participatory mixed method research projects directed to improve participation of people living with complex disabilities in both rural Mexico as well as here in Alberta. And so without further ado, Beto, I'll have you come and give us your talk.
Thank you, Denise. Hi, everyone. Good morning, and thank you for coming in person. I usually attend these rounds over Zoom, so it's nice to see that there's people showing up. I always imagine that nobody was here, right? But that's good. Now I know. Maybe I will make the case to stop by in person. So that's great. Okay, so today I'm going to talk to you about a small piece of one of the projects that I work and collaborate in, because I want to present you this concept of how to use this concept of syndemics to address issues like to evaluate and understand complex interventions in health, which is part of what a community-based rehab project is. So this has been already done formally, but I just want to say, I usually do this more personally. If there is anyone in the room or in Zoom that self-identifies as an Indigenous person, I want to tell you that I acknowledge that I am a settler in your land, and I take advantage of this space to reaffirm my commitment to work towards real reconciliation. Well, real conciliation, because sometimes I doubt that there was conciliation at some point in this history, right? In this colonial history. So I want to present myself as an ally, and thank you. So the disclosure for this presentation, I really have no personal, professional, or financial interests while presenting you these results, right? As you will see. Now, I have three objectives. One is to introduce the concept of syndemics, right, to understand complexity of chronic health conditions. The second is to describe the results of a community, one of the community-based intervention evaluations we're currently doing in one specific area in Mexico. And the third objective is just briefly reflect on future directions of the results of this project that I'm going to present to you. Does that make sense? Okay. So first of all, why syndemic? So let me tell you about the problem that actually we're trying to address here. So the first point I want to make is Mayan people living with multiple chronic health conditions have increased levels of disability, and these levels of disability are exacerbated by living in the adverse socioeconomic context. So specifically these two municipalities, this is the Mexican state of Yucatan. Can you raise your hand if you have been into Cancun or that area? Riviera Maya, okay. So maybe have the room here, maybe in the Zoom we have more. So Cancun is right here. So it's a small state that is on top of here. So this is the Caribbean, right? This is the state of Yucatan, and these two are the Mayan municipalities we have been working on. So just to give you a sense, you have Cancun with a lot of money, usually Canadian and American dollars flowing in vast amounts, and then just a few hundred kilometers away, you have two of the most poorly resourced and socioeconomically poor communities in whole Mexico, right? So it's very startling to go there and see that. Now, on top of that, so we have been doing work in these Mayan communities for a long time, since 2012. So we have a lot of data and experience with this, and we have found so far that. So I want to present this on these layers. And this is like that a PhD student created in Mexico. So we start the level of population. So the population is Mayan Yucatecan communities, and these are the names of the specific communities: Xcalaxonot, Xcoptail, and Yaxuna. Those are Mayan words, not Spanish words. So this population, the big thing that we have identified is that they have a high prevalence of what we call non-communicable diseases or chronic illnesses, mainly diabetes, hypertension, and obesity. But on top of that, for some reason, this particular community or these particular communities, they have a higher incidence of complex musculoskeletal conditions. As you can see, it's at 2.4% of our rheumatoid arthritis, which if you look at the prevalence of rheumatoid arthritis in the world is around 1%. So this is significant, right, in terms of public health. And osteoarthritis is also higher than in the rest, than in other cohorts. And this leads, like all of these things together, this leads to increased pain, right? Perception of pain that leads to disability. But what do I mean by disability? In this case, what I mean is that the people stop being able to work, and they work as individual agricultural farmers, and they don't use technology as our farmers here in Alberta. They work with their bodies. Why? Because the terrain, I don't know maybe if you went to Cancun, you went to the beach, but if you go or you pay attention next time you go, is the jungle, right? That is there, like it's a low jungle. The terrain is really rocky. That's why we hold the cenotes. Have you been in a cenote? Has anyone been in a cenote? Because the water filters, right? So it's very rocky. So that means you don't have a lot of depth in terms of the soil in this area. So the Mayan people have kind of been like living off the land. That is a very shallow land, and you cannot get machinery there. So they use their body to do everything. So that's why we have identified that the biggest issue for disability for them is not being able to continue participating in this life. And that leads to a sense of disruption of their identity. And of course, their quality of life plummets, right? At the beginning, we thought, oh, well, it's pain, right? So let's try to deal with the pain. But then we identified quickly that this is more complex than just pain, right? So that's what we have found so far in previous studies. And then, of course, we started studying all these political, social, and environmental factors that are exacerbating these disabling conditions. That means, by that I mean, when you have arthritis, for example, here in Edmonton, right, and your occupation is an office job, the impact and the severity of the disability could be different or is different as the impact if you are living in a rural Mayan community that you need to use your body to get a living, and you don't have any access to actual management or treatments, right? So those are things that look really logical. We have decades now of the social structural determinants of health literature with us, but of course, no surprise. That's what we found here. For example, like for the case of inflammatory arthritis, in the whole region of Yucatan, the whole state, there are only 5 rheumatologists. Do you think they live in the rural communities? So they live in the capital, which is Merida, right? And that's it. So to get to the capital from the communities that I show you, it's a 5-hour drive not in highways. And imagine that you have pain and you have inflammation and you don't speak Spanish. So all of these things add up for people as barriers for people to access appropriate care. So that's the case, right? So that's the case that I want to present you. That's the problem. So what is the solution? So that's what we came in with the rehab piece. You will say, what are you talking about? Aren't you a physiatrist? Yeah, because this has to do with rehabilitation, right? Rehabilitation in the community, and this is the WHO proposal, what community-based rehab is a multi-sectoral intervention. So that's what I have been kind of dedicating my life during the last 10 years, is try to understand how can we build in these interventions as a complex intervention as a whole, right? And how to measure it, right? So just in a nutshell, I want to show you how complex this is. So according to the WHO, there are 5 main components that you can see here: health, education, livelihood, social, and empowerment. These components have 5 elements each. So the WHO says, if you want a person with a disability to achieve full participation in a meaningful life, you need to have all these elements in place. So the person needs to have access to services that foster all these elements. And it's in the interaction among these elements that the magic is going to happen. So the person is going to be able to function. So you see, it's a complex phenomenon. Now, it's not now like an RCT, like, oh, a question for an RCT. Does this drug work? Yes or no? That's great. You can do an RCT for that. But how can we really understand that is this intervention that deals with promotion, along with the intervention that deals with medical care, along with the intervention that deals with education, along with the intervention that deals with participation in culture and arts? How do they interact to actually produce an effect? And that has been kind of like a headache for all of us to try to tackle. And that's what I want to discuss about with the concept of syndemics. Does that make sense? I will bring this back, just the elements as an example in a later slide when I go to the concrete example. But first, let's stop and say, what do I mean by syndemics? So syndemics, like this was a term coined by Merrill Singer in 2017 from the anthropology perspective, but anthropology applied in public health. And it has the definition has 3 main components. One is, or 3 main assumptions. It says that a syndemic is when there is an interaction of 2 or more health conditions within a population. And it says we should not be, and this is for public health, we should not be seeing the public health of populations or the epidemiology in populations only as a single health condition, because in reality, people live with more than one health condition. So that's kind of one of the biggest assumptions. The other one is that these health conditions interact and produce worse health outcomes. So this concept resonated with what I told you, right? So it's not just to have arthritis, it's have arthritis and diabetes and live in poverty and having to work in a rural area and then having pain, for example. All of these things are interacting, and for us with the result of disability, right? Of not being able to do what you want. And these interactions between health conditions are intensified by the social, economical, political, and environmental factors. So in a nutshell, it brings the literature of the structural determinants of health into this concept. Does that make sense? That's what a syndemic is, when you have more than one health condition and there are different factors that all are going to affect the interaction of these health conditions. Okay, so we started we like the concept and we started exploring it, right? And we have found so far that, and this also has been reported in the literature, that by analyzing or finding this interaction, which is endemic, so you can see the increased burden of disease, the biosocial interaction, and the bio, so health condition and health condition interaction, the interaction of the individual with the environment, and the increased burden of disease, that's what is going to give you the syndemic. So this literature comes from public health and epidemiology. But for us in community-based rehab, we said that's exactly what we will have been focusing for all of these years. That's what we wanted. That is the similar concept, the different language, because it's coming from a different discipline. But that's what we found, the convergence. But so what? So what? Okay, we found it. Perfect. No, well, it has implications because that opened up a conceptual opportunity to do a holistic assessment of inequity in health, to combine biological, social, economic determinants for a more complete analysis, and to evaluate effectiveness of complex interventions, which is what we want to get in our program of research of community-based rehab. Is this story making sense to you? If not, please just let me know, because I know it could be confused. I am confused sometimes as well. So let me go to the example, okay? So we did, this is the third cycle of a community-based rehabilitation program that we do in this region. So we started as actually in 2012. I'm going to present you partial results of the last cycle that is just finishing. Actually, the intervention just finished and the evaluation just finished. So I'm going to present you very fresh results that hopefully make sense. They are not perfect, please bear with me, but hopefully make sense, the concept. So as we do on every cycle, we co-design this community-based rehab program with a participatory research strategy. So in a nutshell, that means we don't come to the community and say, this is what we're going to do. We engage with the community in cycles of understanding the problem, co-designing solutions, implementing solutions, and evaluating solutions, as I can show you here, okay? Here I need to do this, I think. Yeah. So let me just walk you quickly through the method. So this is just to situate you on the results that I'm going to present, right? So usually what we do, so in this case is we develop the community-based rehab program in Skalaxonot, Skoptail, and Yashuna. So we have usually used two, like always, as Denise mentioned, this is a mixed methods program. So we always have a quantitative component and a qualitative component. The qualitative component is an ethnographic study. We're not going to go in depth on that. I'm just going to mention how we're planning to integrate findings. I'm going to focus more on the quantitative component, which is also a before and after design in a community intervention. We don't have ways to randomize, or maybe if some of you can think about ways to randomize people in communities or communities, it would be good. But in our cases, we haven't found that solution. So we just go to our observational designs, right? So we start with a situational analysis. So again, this is the third cycle, as I told you. So we have done this situational analysis 3 times now, which build on the previous cycle, right? So what is a situational analysis? It tells you what is the situation in terms of living with a musculoskeletal disease, chronic conditions, and disability, right? So we usually start with a quantitative component. So this is really, really time consuming. We use census methodologies because these are small communities. We're talking about less than 3,000 people in each of these communities. So we go house by house, asking people about their symptoms, about their chronic illnesses, and then a physician comes and kind of confirms diagnosis, and then if they need a specialist confirmation, we say. So it's a lot of work to do this stuff. We need funding, so we just finished our last round of funding, so that's why we completed a new situational analysis. And this, you can see in the pictures there, this is the environments we're dealing with. Like, imagine those environments at 40 degrees Celsius, 35, 40 degrees Celsius. You just want to die. Going to on each of these houses, assessing people is hard. It's hard work. I have done it in many occasions, and I think I'm getting too old. Actually, my last visit this May, I think I felt I'm getting too old to do this. We need to find another way to continue doing these cycles. And then also we do ethnographic study. So it's not about a census to apply a methodology, a quantitative methodology to understand disease and factors. We also conduct field work, including interviews, participant observation, non-participant observation. Of course, we always hire anthropologists to help us with this. Then what we have, we identify the problems with the community, and we start developing the program. Then this is mostly qualitative because this is dialogue. And then we implement it. And when we implement it, we call it qualitative because, first, there are a lot of things you can imagine in the implementation of an intervention that you cannot quantify, but you can observe. So we register all of that. And then finally, we go to the evaluation, which has a quantitative component and a qualitative component. So this is where I'm going to focus today, a little bit on the syndemic index and the quantitative component. And I will briefly tell you what are the plans, or a little bit of an idea of what are the plans to move ahead with this, okay? Okay, looking at the time, I'm okay. Perfect. So what is happening? Okay. What happened? So it doesn't allow me to go down now. I can do it with the hand. Okay, so let me briefly tell you about results of this last cycle of situational analysis. So it included 513 cases, the cases that I'm going to report here. These are the cases with illnesses, and then the other ones, so like actually it was 2,000 people because we included people without, like house by house, and they were negative in terms of presence of disease. So we put it here, but I just wanted to present quickly the distribution of those who had some sort of problems. These are the variables that we take. And I just want to take your attention to this. This is very, very busy, but I just want to test, like it was 126%, 126 people were identified with osteoarthritis, regional pain syndromes, or rheumatoid arthritis. So that's, we also have some with fibromyalgia, low back pain, psoriatic arthritis, so there were less numbers, but this is what we're defining as our target health condition. And so that means we say the main condition is the musculoskeletal disease, and then the other conditions such as diabetes, we have as a rate of 102, and hypertension are the ones that are added to the syndemic approach, okay? So, now, I'm not going to present all the process to get in here because that's not the purpose of the talk. I just want to jump ahead and tell you what is the model. So what is the community-based program look like that we implemented? So a PhD student created this nice model, and I like it because it has like the shape of a Mayan pyramid, right? So yeah, that's just I think it was creative. But I'm using this to point out what are the components of the community-based rehab matrix that I show you from the WHO. So the first, and I would say the main component, has been medical care and rehab. Medical care consists on bringing, oh, sorry, that's not what I wanted to show, but medical care consists on, let me see, it disappears, okay. So medical care consists of access to a specialist, right? So once you detect that you have a rheumatic disease, so we have rheumatologists from Mexico City, because those 5 rheumatologists in Merida are too busy, right? So they didn't participate, or they don't have time to participate in this. So we bring people from Mexico City to actually provide the care to people in the community, people with rheumatic diseases. But also we bring physiatrists, our specialists, on my specialty, right? We go there But it's very frustrating because you get there, you see the need, but then you don't have an infrastructure for continuity. For rehab, like maybe for rheumatology, it's a little bit easier, and I'm not saying it is, but you just have medications, right? So you have pharmacological management you can start a patient with. And what we have done is, as you see, as the other part is the personal assistant. So we have created a whole network of community members that are activated and can go and get the medications that the person is prescribed on a regular basis. So that means the rheumatologist comes to assessment, start treatment, and then community members are in charge of bringing this treatment to them. So it sounds easy, but it's very difficult in these things. But now add the complexity of not pharmacological management, but therapies such as exercise, such as heat, such as like electrotherapy, things like that. If you don't have someone living there who is prepared to provide these interventions, our work as physiatrists is really frustrating. Of course, we do it. So what, at the end of the day, what do we do? Interventions. So things that we can do at that moment. So basically, joint injections, right? That's what we do. Joint injections of steroids. And that's for people whose main problem is pain. So you can see now that the main intervention of this community-based rehab piece, it's more medical intervention so far. The rehab or the therapy component is not there yet, right? But there is something at least. Then the other one, it's the piece. So we integrate that with the personal assistance, as I told you, so people can get access to those medications. We also have a component of education this time, this education on chronic disease management, right? I'm not proud about it because it started very nice with the community engagement, so trying to get the content that they really need. But our collaborators who did that, and sorry to say, it's good, this is science, right? So that was a mistake. They kind of broke the rules of engagement with the community, and they decided, you don't know a thing, I'm going to tell you what you need to learn, shut up. Oh, what do you think happened? You're still analyzing that, but of course, I feel right now I don't have evidence yet that it didn't work, right? Because we pushed the knowledge that we wanted to disseminate on chronic disease management from the literature from the global north, right? So from Canada, from the States, from Europe. I have my issues with that, but that's part of the intervention, and that's under the lifelong learning on the education part of the CBR. Self-management and empowerment in two ways, because we continue increasing capacity or building capacity of community members, not necessarily with a disease, right, to help their community members with a disease to cope with their illness, but also with people themselves, trying to educate them through this intervention that I told you. It wasn't that stellar in my perspective. And of course, we have the advocacy and justice, which is what we do is connect and reaffirm and strengthen our connection with local and regional healthcare systems and with the municipality authorities. So then at least these people can have free transportation to Merida when they really need it, right? And for example, for labs, rheumatology practice relies a lot on laboratories to define if the disease has been under control. So we managed to get labs taken in the community. So now we have a system in which we educated, so created capacity in the community for community members to get samples of blood, and that the municipality brings those samples to the lab in a city, and then that's it. The patient does not need to go. It's like to go to Merida to get labs, you need to get there at 4 a.m. because there is this culture that if the earlier you arrive, you're going to get a spot, right? Which now it's not. It is just it is not true, but people still does that. So they spend 12 hours to get their labs done, and they have to pay it for themselves. And again, if you have pain and everything else, so it's not comfortable. We have all that documented in qualitative research. Okay, so those are the components of the community-based rehab that we implement. Okay, so these are just some pictures. This is the regional hospital in Valladolid, which is near Chichen Itza, right? If you have been to Chichen Itza, this is the area. This is one of the community workers, like delivering the medications, like ready to deliver medications in the community. Medical care rehab. This is one of physiatry residents from Mexico City that I brought there, and we were doing some knee injections. This is an education session. As you see, it's very, very, not very circular as they do stuff, but anyways, that's what it is. And this is the coordination of sorry, I don't know. Okay, I'll move on. But that was the, yeah, oh, come on. The coordination of, like, that was us coordinating with services in the region. Okay. So now let me go to the important thing, my point about syndemic. So we have this intervention, okay? So how do we approach the analysis at this moment? So I just want to walk you through this syndemic analytic approach. So this is how we are doing it, and this is done with the support of the UNAM. UNAM is the National University of Mexico, Autonomous National University of Mexico. They have an Institute of Applied Technology and Sciences, and there is a mathematician that is actually doing all this stuff and teaching us about this, and we're collaborating. But this is in a nutshell what we do. So we go through all the factors, like all these variables that we're taking during those census that I told you. And of course, we do it in baseline and then after the intervention. So it's a lot of work there, right? So there are socio-demographic, clinical, economical, environmental, and cultural factors. Then we start very simple with through logistic regressions, trying to get which of these variables are really associated with a person having a syndemic, which means having the musculoskeletal condition plus at least one other health condition. I think our approach is still not perfect because that's not what we want. We are kind of like a chicken and egg thing, right? We're saying, is having all these factors resulting in you having more than one disease? Or is having this disease, right, actually provoking these factors? So we don't know. For some factors, it's a chicken and egg. For some factors, it's clear. For some factors, it's not. So at this moment, this is the way we approach it. So after this logistic regression, we identify the variables that are mostly associated with being or not in a syndemic status, right? And once we have that, we normalize the continuous variables, right? And the dichotomous variables, we just assign 0, 1, and then we aggregate it, right? So that means for each person, there's going to be a syndemic index, as you can see here. So we create a continuous value that goes from 0 to 1, meaning 0, it's lower syndemic, 1 is higher syndemic. Means that you have, on top of having those two things, you have more of these factors that were significantly associated with you having more than one disease. Okay, so that's the first step, and you put that into like in the data, and then the next step is to do the analysis network, right? So this is how the mathematician has explained this to me. The whole idea is this. We usually, our business as usual in quantitative research and analysis is to study average data, right? So at the end of the day, all our inferential analysis is about what the group means, medians, whatever it is, what is average data. So what we're doing with this syndemic analysis approach is that we start with the average data, we identify which variables are really of interest, and then we try to go back to individual data. So that's why, based on that, we assign labels to each individual, right? And then we run a network analysis in order to identify those clusters of people that have this similar factors or similar characteristics in terms of all this syndemic thing. So then with that, we will be able to identify or to answer questions such as, what are the main factors associated with having 1 or 2 or more diseases? That will be more like a diagnostic piece. But then if you do this 1 and 2, right, with baseline and after an intervention, that's the interest of today, right, we can find how these clusters change or not. And that could help us to understand if there was an effect of the whole thing. You see, the interaction piece. Does that make sense? That's kind of how I understood it from the mathematician, and I will give you the results just to give you a sense. I don't think they're perfect though. That's the thing, right? Mathematicians love numbers, but we need to give them the interpretation, the meaning of those numbers. So it has been very interesting interactions, but that's in a nutshell how it works. And the other thing I just want to mention here is that because of this approach, going back to the unit, to going back to the individuals, we are now able to bring the qualitative data in. So that means the interviews, the narratives of these individuals could help us. Like if we found them in a cluster, we can go to those interviews and help us to understand more in depth why they change or why they are there. And then we can transform the qualitative data in quantitative data and even put it back into the model and test the hypothesis, right? So that's the whole idea. So just an example. This is a preliminary analysis on 154 people. We are really, well, I'm not, but the mathematician was really, really upset because the follow-up data was really low. Like there was a lot of missing data. And of course, the responsible for doing this data collection at this moment was our 2 PhD candidates that are going to finish their PhD soon. And he was really mad. So we're going to have to talk and see how we can rescue things. That's one of the things. In these cases, we cannot do imputations and things like that because that's not reality. We cannot create cases. If you lose them, you lose them, right? And that is and that tells you the difficulties of doing community-based rehab like this, right? Community-based research is really hard to get data. So all of this is in Spanish. Sorry about that. We didn't have time to translate it. But these are so we start again with regular non-parametric tests. Wilcoxon and McNamara, according to the type of data. Why only 154 I'm showing up to you today? Because the incomplete data, we didn't have more, right? So out of those 500, and then remember there were 162 with the syndemic index, we ended up having 70 with the syndemic index and the rest without the syndemic index. So the power really went down. That's why the mathematician is not happy at all, but I will present you the concept. And I'm sure we're going to be able to fix this somehow, but I'm going to show you the concept like this. So I started by doing this, by doing the parametric test and identifying which variables have a more big effect size, and of course, with a hypothesis testing of p-value. And what we found is that these are the things that were really, salient in this population, which were deals with body functions, the body functions of blood pressure, pain, VO2 max, which is a measurement of activity or aerobic endurance. There were some variables about activities such as dressing, going to the bathroom, opening jars, and participation. There was only one, which is this one here, which is doing something at home like washing dishes or cooking food or prepare the terrain, right? So those were kind of significant, but not everybody really made it. And there were no environmental factors. Why is that? Because remember, this is the population that actually had complete data from baseline to follow-up. Of course, they're not going to be significant because we are not changing poverty. We're not changing income. We're not changing transportation. Maybe that's those. You see how community-based rehab forces us to address those things. But look, we are addressing this problem by giving medications. But that's good. Or bringing a specialist. That's great. But of course, we're not changing the syndemic part from the structural things, right? So that leads us to reflect that we need to do more collaboration with other sectors like education and social services, right? Okay, I'm going to go faster because I only have 5 minutes. So The next step, so we identified it. So these were the variables selected, right? So now what the mathematician did was he did an odds ratio analysis. Source A meets baseline, source B means follow-up. But I want to tell you, if you're on this side of the column, you are favoring the syndemic, so it's negative. If you're on this side of the column, you're protective, right? Remember, because the outcome is having MSK condition plus one or more health conditions. So everything here is not having it, everything here is having it. So at baseline, the only things there are three things I want to go back and forth just to make it justice to what the mathematician explained to me. First one, the greater uncertainty and follow-up. I just want to see, how do you see the greater uncertainty? You look at the distribution. You have your mean, and then you have the distribution of the variables. So you see, if, for example, this is presión sistólica, which means systolic blood pressure. It's on the same side, right? On baseline but you see how the confidence intervals got bigger or larger? So that's what he means by that. So the confidence intervals got wider. Why? Because we lost patients. Well, we lost participants in the follow-up. So that's why, and that happened a lot in most of the variables. Now, the variables that I want to bring your attention to. So there are some variables that change. Two variables that change from being associated with syndemic at baseline and then being associated with no syndemic at follow-up, which were grip strength and pain. Let me show you here. Grip strength here is the dyno test here. So you see how started baseline being associated with the syndemic. Now, sorry, I don't know why he did this, but it's not this dyno test here. It switched to the other side. You see, it switched the line. However, the confidence intervals are still a problem. So we have a lot of uncertainty. But at least this is telling us a story, right? The other one was what's the one that I told you? Grip strength and pain. Pain is more obvious. You can see pain is here in, where is pain? Where is pain? Where? Come on, here it is. So it started on a factor for syndemic, and then let me look for it here. And then it goes to the other side, right? But still, the uncertainty because of the loss of data it's still a problem, right? So those are the ones. And then finally, the other piece is there were some body functions and activities like the VO2, the glucose levels, the diastolic blood pressure, but not the systolic blood pressure. And the activity of dressing remained on the protective side or on the on this space. What happened with this, for example, this is the VO2. Let's look for VO2 here. The uncertainty reduced. So there is something here that actually tells us that maybe the capacity for walking and I didn't tell you about the methodology, how do we measure this, but the aerobic capacity somehow improved, right? So it was good at the beginning, but it was better because this uncertainty reduced. And that's the same thing that happened with glucose. Also, actually, no, with glucose. No, I didn't say glucose. What was the other one? Oh, yes, glucose and the diastolic blood pressure. So you see, glucose is here, and then glucose is here. Actually, that's the opposite side. So I shouldn't say that. This one was more certain here, and then it kind of turned to the other one. So maybe they worsened in the glucose levels, right? Now, let me move to the next step. So the next step is, and another observation that we did is historical pain. So this is a question to the people: is have you ever had pain in your muscles, joints, etc.? That's historical pain ever, right? So you expect that if you ask the same question in the follow-up, that wouldn't change, right? But look at what happened in historical pain, which is this one. Historical pain is starting to be protective here. Sorry, no, a factor in favor of syndemic. And when we go to historical pain, here, it goes to the other side. So that doesn't make sense. So there was something wrong in the interpretation of the people in the community to that item of, have you ever had any pain? Is this important? Well, for us clinically, the importance is that maybe we didn't do a good job in the education sessions, right? People continues to be as confused as ever about their disease and etc. Yeah? And okay, so the next step was the significant variables from this OR that I showed you, the OR radius, were used to calculate a similarity matrix for all the subjects. Remember, going back to the individual, right? And what model in HEPI, right? That's the software that he uses to do the network analysis. So similar nodes, so just to give you a sense, so you will see it, similar nodes are close together in the plot. So that means they use a matrix that is called, oh my goodness, attraction and repulsion. So attraction, that means people that have similar things that are really, really close together. And repulsion, it includes the distance between those people that are different is shown. So this is how it looks, right? So you have a network analysis on the baseline, right? And you can see here that there is high variation. So on green is you have your people with syndemic. On red, the people that didn't fulfill that they will call them healthy people, right? So what you can see here is that it's quite not well distributed, right? So there is an area of higher density, but not all syndemic individuals are in the same area. So what is happening here? After the intervention, there were two clear nodes following, two clear clusters. These ones, we don't know, we need to check on them. So the interpretation so far is that the intervention impact was not the same for everyone, right? And what we need to, and that's why I tell you this story is incomplete, because we need to go into these cases and understand why they are now grouped into different clusters. So something changed in there. Maybe, remember when we look at the odds ratio that changed for the grip strength, right? Maybe in one cluster, you have the people who actually improved in the grip strength, and there were other factors related to that versus the ones that didn't improve. But he finished running this yesterday at 1 a.m. So of course I couldn't push the guy to go into depth, but I just wanted to use this as an example of how the process is. So this is not finished. Now we need to go into these clusters, understand them, and then qualitatively identify some of them and say maybe the qualitative data can help us understand why this community changed from baseline to after the intervention. So at least it's telling us that something changed. We don't know if it's for worse or for good yet, right? The odds ratio at least are telling us that people are improving grip strength and pain, which makes sense because if you have less pain, you have more grip strength. That means that at least the medical intervention of the community-based rehab project had an effect. But the other stuff that we were really wanted to change, maybe not. But you see, if we stay at the group level, we will never know. We will conclude this whole effort of a year doing this resulted on these things, maybe improve pain and improve grip strength. But the rest of the variables, no. But now we have a different tool. So instead of staying there, understanding what is really what happened by going back to the individual, okay? So limitations, as I told you, incomplete flow of data, high uncertainty around the variables. I already told you, walked through these problems. And of course, we haven't done the integration of qualitative research, but that we're on the works to do that, okay? So interpretations and conclusions of all of these analyses that I'm telling you is that there are some positive changes apparently on the syndemic populations on grip strength and pain, which for me indicates, and this is my own interpretation as a clinician, that the medical and the rehab interventions, because they were actually directed to pain control and inflammation, that's what we're seeing as an effect. But the other ambitious things to improving empowerment, to improving participation and functioning, apparently we're not touching them. Why? Because these are complex phenomena. So we need to do more in our community-based rehab, but at least we're learning from it. Before, we didn't know this, right? We need to explore the resulting two clusters. That's what I told you about. And I conclude that the systemic approach can help us to understand. If you guys here have an idea or anything that could help with this idea or even going through another direction, I would love to hear it, because that's the big issue I have in my program of research, is how to measure these complex interventions. Future directions, right now, I will say it's improve the rehab component. Rehab is not just about interventions, as we see. Yeah, we're going to improve pain, but we're not going to improve participation in a meaningful life, right? So we need an extra there. Also, add the empowerment component. We have failed to do the empowerment component. So remember, empowerment component is to bring power to the people living with the chronic condition so they can take care of themselves. So I think that's a big one. Working on the sustainability of the intervention, because that's the other piece. We have funding, we did it. We tried to get it immersed in the system, and we failed again for the third time. And that's why, because politicians, they are there for 5 years and they don't care about anything that has to do with sustainability. They tell you, yes, I'm going to take the picture, I'm going to give you the support, but goodbye. I don't care about the sustainability piece, right? And we will integrate more environmental factors and the livelihood. That's the thing that I want really to work with the mathematician is we need to include in these models. I don't care if they're not like the structural or the social factors are not significantly different in your initial analysis, because this is not about numbers, this is about logic, right? We need to include this in the model. So we need to have this conversation still. Finally, just an example of future directions for the sustainability is to continue at least to maintain the positive effects on the pain and on the access to specialized care. We are looking now at the concept of extended reality. There is a PhD student actually working on that institute that she is working on building us an augmented reality setup in the community and in Mexico City and here. And so the plan is that she comes here and put a setup here at the UFA with me. So we can continue seeing these patients as if we were there. As I told you, I'm too old to continue going and doing these assessments. And also it's better to see them regularly, not like every year or every 2 years, right? So the continuity of care, and importantly, this will help to continue building capacity on the other side, because this technology will be implemented by community members on the community, right? And using this extensive reality. I have a whole picture of her plans and how she's developing this stuff, but I don't have time to present it because that's another topic. But I just wanted to present this to you as a future direction that we are currently in the making. I will call it the fourth cycle of our intervention. However, we still need to engage with the community, because we are jumping on the gun and say, yeah, that's what we're going to do, but we haven't done a proper community engagement piece. So that's something that needs to come in the future. So I hope that I was able to at least show you what my problem is and the way that we address this. These are all the people involved. And I acknowledge Alfonso Gastelum is the mathematician, and I want to give him credit because he put the work until 1 a.m. so I can present you some of this to date for you. So thank you very much, and I'm waiting for some questions.
Thanks, Beto. I'm going to actually look and see if we have any questions online, but any questions in the room?
So why a rheumatologist from Mexico City? Why not a good generalist and family doctor in the community?
Excellent question. Because we have tried everything. These communities used to be run by medical students. So in Mexico, we have this weird thing that I went through as well, which is called the social service. So when you study medicine and you finish medicine, before you can get into your kind of like internship and residence and all that, you need to go to a rural community and live there for a year. And in my time, and the time when I arrived there, you are the only physician in charge of that town. So we tried with them. And of course, first of all, they are young, they don't care. And the most important thing, they're going to leave, right? So we tried and it didn't work. Now we have people. So Mexico, the health system has improved, and now they hire people. So you still do the social service, but you have a person in charge, so a physician in charge. So now we're working with them, and that has been kind of like we have established that connection between the rheumatologist and the family doc in these units, and that has been a world of difference that I think is showing in the results, because now I wouldn't, your question made me think that maybe I was too harsh on us. There has been systemic changes that have been sustained, which is this, like now people with rheumatoid arthritis in this community, that they can be detected earlier, and the ones that have it, they have direct access to family doctor has direct access to the rheumatologist in Mexico City. So that has
the majority of your population didn't have rheumatological disease, they had osteoarthritis, fibromyalgia.
Yeah. Exactly, and that's the other big piece is that's where pharmacological treatment is not as powerful. So we need to invest in the other part of rehab. So we're physiatrists, we're trying to, but that has been an issue. Why? Because funders, they love medicines, they love physicians, they don't understand rehab. So we have, like the funding we have had in the last cycles have been very directive to that. But that doesn't justify it. Like that, I think that was a mistake on my end. I dropped the gun there because I was transitioning to this position and all of that. But I should have made a better job to make sure that the rehab component at least was the same quality as the one that we did before, because I already present the previous cycle in these rounds, in which the changes in activity limitations were significant. But now we lost that because I decreased.
There's a question online about chronic renal disease, which apparently is increasing in this population, and just wondering whether or not you took that into account and how it might interact with pain medications.
No, that's a great. No, we didn't. We do have internal medicine doctors helping us with this at the university, but then the risk with the university that we worked was lost because they did that education piece. They broke the engagement rules, and that's so we relied a lot on that person, like the internist, on this piece. But that's a great point. We didn't explore renal function. We just, because this is community. That's the thing, right? Like going house by house, doing like the glycemic, what do you call it here in English when you do the pin here for the glucose? Oh, the glucose levels, but that is what's called the capillary.
Capillary.
Yeah. So that's the only thing we could do. We did blood pressure, weight, but what we don't have the tools. If there are some tools to measure renal function in the community, that would be fantastic. If not, we do have the community lab piece set up, and that's potentially another way that could be done. But no, we didn't consider that.
I hate to ask this last question online because I'm not sure it's a short answer, but the person acknowledges that it's an interesting intervention concept, but wonders if it's scalable to other jurisdictions outside of Mexico, and any value in applying the MRC framework in the evaluation process, as this is a complex intervention.
Oh, definitely. The MRC, like I know the framework for complex interventions. Definitely, we look at that. We have looked at that for a long time, and that's what we decided to go with the syndemic approach to help us align our understanding between the mathematician side, the statistician side, and the clinical researcher side. So I don't know if that answered part of the question. The other part is definitely I feel I'm really, really keen to implement this in the other stuff that we're doing here in Alberta, and see how applying this type of analytic approach used in network analysis under this syndemic concept, I definitely think is applicable. I don't see why not. Right.
Yeah. Excellent. Well, given that we have 30 seconds till 9 o'clock, and I know our cutoff is, I was given specific instructions, not past 9 o'clock. So thank you very much for your presentation this morning from everybody here in the room and also online. And I wish everybody the rest of a great day.
Thank you.